All right, welcome back, everyone. This is day 2 of our schedule, the 9-day schedule to finish everything except internal medicine in USMLE Step 2 CK. We are reading from Master of the Boards, USMLE Step 3, for everything except internal medicine. We have just finished dermatology and preventive medicine. That's great. That's day 1. We are done with day 1. And now we're starting day 2. Day 2 is going to be surgery all day long. We're going to try to do 30 pages. But before I do, I'd like to apologize for not being able to upload videos on a regular basis here and for not being able to record sessions for the past couple of weeks. I've been really sick, and it prevented me from being able to read or to do anything. I apologize again. I'm going to try to catch up as much as I can. I'll try to do 2 days and 1 day from the schedule here, but we'll see how it goes. So let's get started. We are starting with section 4, surgery, and we are on page 309. So if you would not open your book on 309 and just follow along if you would like. All right, so we are starting first with trauma. Trauma is going to be the airway, the breathing, and the circulation. So that's the ABCs here. That's very important, emergency, and we need to be able to identify those emergencies and to work with them right away. All right, so let's start with airway. Airway, first, establishing and securing the airway is always the first step in management in any patient with any acute trauma or change in mental status. That's the first thing you think about. A, and then B, and then C. We all know that. An altered mental status is the most common indication for intubation in a trauma patient. In a Glasgow Coma score 8 or below, I think, that's when we start to think about intubation, and any patient who has altered mental status, we should think about intubation right away, especially if the patient is in a state of trauma. The exam will want you to know the best step in securing an airway. So there are 3 things to talk about. First, the oral tracheal intubation. This is the preferred method for securing the airway, of course. In case the question describes trauma with cervical spine injury, orotracheal intubation can be still performed with manual cervical immobilization, but the best answer is to use the flexible bronchoscope. So again, first thing to do is think, oh, well, I'm going to do orotracheal intubation. This is preferred in any patient to secure the airway. Well, what if there is a trauma with cervical spine injury? Well, we still do the orotracheal intubation, but with manual cervical immobilization. The best answer is to use a flexible bronchoscope here. If the case describes extensive facial trauma and the bleeding into the airway, that's really, it's going to be really hard to do a orotracheal intubation. What we're going to do here is do a cricothyroidotomy. This is the best answer to use here. It's a percutaneous tracheostomy is also acceptable as well. You can do this or that, whatever is in the answer. So cricothyroidotomy and percutaneous tracheostomy. That's how we secure the airway here in a patient who has extensive facial trauma. All right. After the airway, it's breathing. We always check the oxygen saturation. If the saturation is below 90%, we do the following. First, we obtain an ABG, arterial blood gas. We determine likely cause of hypoxia based on the history. So if we can question the patient, we'll go on. If you can't, then you should suspect it based on what you know. A basic sign score rate, we should know that the normal PCO2 is 40 and the normal bicarb is 24. Of course, there is a range, but this is just the values that we can use in the exam. Now, after the breathing, the circulation here. Circulation, first we need to talk about chest trauma, and then we're going to talk about abdominal trauma, and then the vasomotor shock at the end. Let's start with the chest trauma here. Circulatory disturbances in the setting of trauma may have one of 3 major causes. So we have 3 major causes that could cause circulatory disturbances. In the exam, you will need to determine quickly the likely cause to institute prompt therapy. So we should think about the cause so we can actually direct our therapy here. So first, one of the three is the hypovolemic shock. This is the most common type of shock here. We look for a source of bleeding. Let's say the patient is bleeding from an apparent arterial injury. The patient here, when we lose a large volume of blood into the abdomen, for example, as well, or in the thigh, if there is a diaphyseal fracture of the femur. It can be up to 2 liters, I think. We should know that in hypovolemic shock, a right arterial pressure is going to be decreased. Why? The right arterial pressure is going to be decreased because we're not having any return of blood. The second thing is that pulmonary capillary wedge pressure is also decreased. The cardiac index is decreased. Systemic vascular resistance is increased. Mixed venous blood saturation is decreased. So that's in hypovolemic shock. Right arterial pressure, pulmonary capillary wedge pressure, and mixed venous blood saturation, cardiac index, they are all decreased. The systemic vascular resistance is the only thing that is increased. As a side note, we should not be distracted by head trauma or dilated pupils in a hypotensive trauma patient. Intracranial bleeds are never the cause of hypotensive shock. The first step in management is to identify and control the site of bleeding. Okay? All right. Now let's talk about the second thing, which is the pericardial tamponade or tension pneumothorax. Those two things can both result from a thoracic trauma. They both result in a distended neck veins or a high central venous pressure. So we should look at the veins in the neck, GVD. If it's increased, we should think about pericardial tamponade or tension pneumothorax. How are we going to differentiate a little? Well, the pericardial tamponade is going to involve the following. First, we're going to have an enlarged heart and chest X-ray. Immediately, we perform the pericardial synthesis, and if it is unsuccessful, we proceed with the pericardial window. There is going to be electrical alternates on the EKG. There is going to be a pulsus paradoxics on the vital signs. All right, so take a breath, and there's going to be a difference in the pulse here. That's how we tell if there is a pericardial tamponade. If it's going to be a tension pneumothorax, however, we look for respiratory distress. Of course, we can look into tracheal deviation, either by hand or in an accidental X-ray, if that is the case. If there is an absent breath sounds here, and it is hyperresonance to percussion. So those are all indications for tension pneumothorax. What we do, we immediately place a large bore needle or IV catheter into the pleural space at the second intercostal space, of course in the side where the tension pneumo is. Then place a chest tube. Okay, so first large bore needle or IV catheter, pleural space, second intercostal space, and then a chest tube. And then we never wait for a chest X-ray for a diagnosis. All right, so never wait for a chest X-ray for the diagnosis. All right. So we said hypovolemic shock, pericardial tamponade, and then tension pneumothorax. How about an abdominal trauma here? Well, we have a really good question. We can read the question here. It says that it is a 24-year-old male with a history of gang violence presents to the emergency room with a 3-stab wound to the abdomen. He was intubated in the field for airway protection and is barely conscious. Blood pressure is low, 70 over 30 millimeter mercury, and pulse is 140 per minute. On exam, he has 3 penetrating wounds covered by abdominal pressure pads. They are noted. Which of the following is the best next step in management of this patient? We have here 5 options. We either direct pressure on the abdomen, we do an abdominal X-ray, we do IV fluids, IV antibiotics, or obtain consent for surgery. My answer would be IV fluids right away because this patient is in shock. His blood pressure is really low, he has high pulse, and he has a source of bleeding. That would be the case. So let's see what the answer says. It says here C. Yes, of course. This patient is in hemorrhagic shock and requires immediate resuscitation. Of the choices listed, the best next step in management is IV fluids, of course, after obtaining venous access. The best form of venous access is 2 large bore IVs in the periphery and or a central venous access. We apply direct pressure, of course, to the abdomen, but this does not treat the underlying cause. This is just to stop the bleeding temporarily. We get an abdominal x-ray. This is not going to be necessary here. It will take too long for the patient, and he's going to die from blood loss before we actually get any diagnosis here. IV antibiotics, well, he's going to need it, but not right now. At the moment, it's not really a pressuring or a pressing matter. We need to stabilize the blood pressure first. The surgical consent, well, it is implied in this case that he's going to need surgery. We don't really need the consent. We just go ahead right away. Okay, so the management of circulatory disturbances in cases of abdominal trauma should involve the following here. Well, while you are doing your initial survey of the patient, it is imperative to simultaneously control the site of bleeding. We apply a direct local pressure when the site is visible, like say the extremity, just direct pressure either with your hand or whatever you have. A blind clamping and the use of tourniquet is never the answer here. Okay, so if local pressure on the site is visible, blind clamping and the use of tourniquet is not a good answer. The second thing is fluid resuscitation. This is always the best next step in management in a patient who is hemodynamically unstable, just in general. And then we do several things at once in preparation for immediate exploratory laparotomy. First, we set up two large gauge IV lines, give fluids and blood, type and screen, insert Foley catheter, and administer IV antibiotics. If surgery isn't needed, like say it's a blunt trauma, fluid resuscitation at the first step in management is also a diagnostic as well. If the patient responds, then he is no longer needing. He is probably no longer bleeding. A side note says here that intraosseous cannulation in the proximal tibia is used in children, generally less than 6 years old. We give an initial bolus of ringolactate at 20 milliliter per kilogram of body weight. So we can use that instead of the IV lines here. All right? Okay. Great. Now we're done with the abdominal trauma here. Let's talk about vasomotor shock here. A vasomotor shock is the cause of hypotension and tachycardia in a patient who are warm and flushed, rather than pale and cold, which we actually see in a shock in general. We look for a history of medication use, let's say for penicillin, that maybe triggered a penicillin allergy, for example, spinal anesthesia, or exposure to allergen like a bee sting. It should be noted as a basic science correlate here that we can get that on exposure to a foreign substance, IgE binds to the antigen, forming an antigen-antibody complex. So this is the first type of hypersensitivity here. This complex activates the high affinity receptor for the Fc region of immunoglobulin E. So there is an Fc region in some called immunoglobulin E, IgE, and the complex activates this high affinity receptor here. Then, this leads to mast cell and basophil degranulation and release of inflammatory mediators such as histamine. These mediators will cause the vasodilatation, bronchoconstriction, tachycardia, and swelling, and so on. It says here that the first step in management is to administer vasoconstrictors and the fluids. So again, we should not think about something like, say, antihistamines or steroids or whatever. It's not either the what's called epinephrine or something like that. The first step in management is to administer vasoconstrictors and fluids. Vasoconstrictors and fluids. Okay, so epi would be actually a good thing here as well. All right, let's say we are done with vasomotor shock. Now we are going to talk about trauma to localized sites here. Okay, so it says here that all penetrating wounds with damage to internal organs will need to go to the OR. Okay, so that's the general rule here. If the case describes an object embedded in the patient, never remove it in the ER or at the scene of the accident. All right. A side note here says that all impaled objects are to be removed in the OR under a controlled setting. Okay, so that complements what we just said. Okay, let's talk about those specialized or localized sites. First, we're going to talk about head trauma. The management steps for the exam here. Well, a man was hit over the head with a baseball bat during a mugging. He has a scalp laceration and a linear skull fracture on a CT scan. He denies loss of consciousness here. There are no neurological signs on exam. Is surgery indicated? That's a really good question. Well, the answer is no. Surgical intervention is needed for an asymptomatic head injury with a closed skull fracture. So there is no overlying wound here. Alone. The next step in management is to clean any lacerations. All right. A second question. A woman was hit over the head with a baseball bat during a mugging. She has a scalp laceration and a comminuted depressed fracture is seen on a CT. So that's different here. We said a linear skull fracture, it's not mobilized. And here, it is a comminuted depressed fracture is seen on the CT. She denies loss of consciousness. There are no neurological signs on the exam. The surgery indicated. The answer here, surgery, repair, or craniotomy is always done for comminuted or depressed skull fractures. So that's the difference here. If it's comminuted or depressed, then we should do surgery. If it's just a linear skull fracture that is not mobilized, then we should not really do anything about it. Even if the patient is asymptomatic, actually. So what we do, send the patient to OR if he has a comminuted or depressed skull fracture. All right. Another question here. Well, what if a man is hit over with the head with a baseball bat again during a mugging, reports being out of it for a few seconds, so he lost consciousness. But then he came to without any symptoms. There are no neurological signs on the exam. What is the next step in management? He wants to go home. What will you tell him? What would you tell him? Well, the answer here is that for a head trauma and loss of consciousness, the first step in management is to order a CT of the head and neck without contrast. We should check what is going on. If the head CT and neurological exams are normal, he can go home if someone can closely observe him for the next 24 hours, which means wake him up frequently and watch for changes in mentation. Okay? All right. So, loss of consciousness, nothing on the CT, and everything is okay. He can go home, but someone has to watch him for 24 hours. Wake him up, see if everything is fine or not. A side note says that we give tetanus toxoid and prophylactic antibiotics to all patients with open skull fractures. All right, that's understandable. All right, the second thing here that we need to talk about is the basal skull fractures. What we look for in a basal skull fracture, we will look for ecchymosis around both eyes, raccoon eyes. That's really actually very famous, we see it all the time. Or behind the ear, which is the Barrel sign, or clear fluid dripping from the ear or nose. That's cerebrospinal fluid, of course. How are we going to manage such a patient? Well, first we do a CT scan of the head and neck just to see where the fracture is. This will show us the basal skull fracture. The X-ray is not the correct answer here. CT scan, that's going to show the fracture. And a CSF leak will stop by itself and requires no specific management. We just give antibiotics, and prophylactic antibiotics are not indicated. I'm sorry, we do not give antibiotics, so prophylactic antibiotics are not indicated. So the CSF leak, we don't do anything about it, just it's going to stop. The third thing we should think about is facial palsy. This may occur 2 to 3 days later due to neuropraxia. Okay? All right. So, again, basal skull fracture. Basal skull fracture is ecchymosis around the eye or behind the ear, a clear fluid dripping from the ear or nose, which is the CSF. We do a CT scan of the head and neck without contrast, and we will show the basal skull fracture here. We do not do an X-ray. CSF leak is going to stop by its own. We don't give antibiotics, and the facial palsy may occur 2 to 3 days later. Okay. Now let's talk about epidural hematoma here. An epidural hematoma, let's say that there is a 14-year-old boy and he's hit over the side of the head with a baseball bat again. He loses consciousness for a few minutes, but he recovers promptly and wishes to continue playing. He's brought to the ER, however, and the CT is shown in the image below. It says here, show a really a white area on the left side, as you can see if you open your book, of the CT scan. All right, on the left area, I'm sorry. The patient has no complaints and has no neurological dysfunction on the exam. So, what do we do? Do we admit him and observe him for 24 hours? Do we perform emergency craniotomy? Do we give mannitol? Do we send the patient home with frequent neurological checks? I think we should perform surgery here, but let's see. It says here the answer is B, of course. It's perform emergency craniotomy. The patient is at risk of sudden deterioration here. Emergency craniotomy is needed for all epidural hematomas. So let's see. How can we tell this is epidural hematoma anyways? Well, an epidural hematoma is biconvex. Okay? So biconvex. That means that it's going to be specifically different from the subdural hematoma in that part. It also follows the middle cranial artery, and there is a meningeal artery, and there is a lucid interval. So what we should be looking at is that of a biconvex looking shape of bleeding or hematoma on the CT. How we're going to differentiate it from the subdural? The subdural is actually going to look like a crescent, and there will be a bridging of veins here, and there's going to be a gradual loss of consciousness. But epidural, it's going to be different. Again, biconvex, it's going to follow the middle meningeal artery, and there will be a lucid interval. So, the epidural hematomas, we said that it presents with trauma and sudden loss of consciousness. The period when the patient immediately awakes and appears normal is referred to as a lucid interval, but then the patient quickly deteriorates. It is important to move quickly, however. We're going to diagnose them with a CT scan that shows a lens-shaped hematoma, or again, the biconvex, with or without midline deviation. So we can see midline deviation, or we cannot. We're going to do an emergency craniotomy. If the patient is treated, the prognosis is really good. If not, it can be fatal within hours here. As a basic science correlate, we should talk about the middle meningeal artery here. The middle meningeal artery is the third branch of the maxillary artery, which is a branch of the external carotid artery. So the carotid is going to be internal and then external. The maxillary artery is going to be one of the branches of the external carotid arteries. And then it has a third branch from the maxillary artery, and it's going to be the middle meningeal artery. All right? Okay. So, a chronic subdural hematoma, however, how is it going to be? Well, a chronic subdural hematoma here, the bleeding is low pressure from the venous system, so that's different. And we should suspect a chronic subdural hematoma in a case of head trauma with fluctuating consciousness. Let's say there is a gradual headache, there is memory loss, personality changes, dementia, confusion, and drowsiness, and so on. So we should suspect something like that. And of course, if there is a trauma. We're going to diagnose it as just like we did before with the CT scan, but it's going to show a semi-lunar or a crescent-shaped hematoma with or without midline deviation. Again, what we're going to do is it's the same. We're going to do an emergency craniotomy, but it is only done if there are lateralizing signs and midline displacement. Otherwise, we do not do anything. A side note says that to rule out bleeds in the brain, order a CT scan without contrast. Blood and contrast look the same on CT, which will give a false positive here. So, as a basic science correlate as well, bridging veins drain the neural tissue and puncture through the dura mater to empty into the dural sinuses. So the bridging veins, they drain the neural tissue, puncture through the dura, and empty into the dural sinuses here. Okay. So this is how they end. Now the final thing that we're gonna talk about in this video here is the diffuse axonal injury. A diffuse axonal injury would result from acceleration, deceleration injuries into the head. So someone who's in, say, a car accident. The patient will be deeply unconscious. The prognosis here is terrible, and surgery cannot really help. Therapy is directed at preventing further injury from increased intracranial pressure, and that's it. So this is diffuse axonal injury. And on that note, we're going to end this video here. That's 25 minutes. Let's take a break. I'm going to catch a cappuccino here or something like that and be back in 5 minutes. All right. Bye-bye.